Can you guys hear okay? I know hearing can be a little challenging.
It's a lot easier to hear.
Then the bigger video. Okay. Well, let's go ahead and. You want me to move this stuff, Aaron? What? You want me to move this stuff?
Yeah.
Here we go. Okay. So today may seem somewhat male-centric, and it is in the sense that a lot of the conditions are going to be more male-specific conditions, and the reason that we'll be doing that is we'll have dedicated obstetrics and gynecology lectures in special populations where we'll focus almost entirely on women's health issues, reproductive issues, urological issues, and gynecological issues. Although there is some significant crossover, specifically when it comes to UTIs and renal calculi. But let's go ahead and talk about our male-specific stuff first. And real quickly, I just want to review the anatomy and physiology of the male, human male genital and urinary tract. So is this familiar to all you guys? Are you guys okay with these? Remember all this from anatomy and physiology? So hopefully. Okay, so let's just take a look at this. So here's your ureter. You guys are okay with that, right? We're done. We're good with kidneys. The urine comes down into the bladder here. And then the urine leaves the bladder through the urethra, like outside of the body. But we have all these other structures that I want to just cover real quickly. So first of all, I have the structure hanging down here, and this is known as the testicular sac. And what's inside the testicular sac? Okay, so you have so you have a testis in each one, or testes, we're talking about both of them. All right. And then if you were to cut away, as I've done here, one of the testes, you would see these little cavities full of these little tubules, and those are known as seminiferous tubules. And what's going on inside the seminiferous tubules? Yep, spermatogenesis. That's where spermatogenesis occurs. And this is also where male sex hormones are created and released into the circulatory system. Okay, so testosterone specifically. Okay, not the seminiferous tubules themselves, but associated tissues. Okay, all right. So you have spermatogenesis occurring there, and then the sperm, the spermatozoa will actually migrate out of the testis, and it will migrate into a structure that's attached, okay, to the testis. And what is that structure known as? The epididymis. The epididymis. You guys okay with that? And the epididymis is a sort of storage area for sperm. It is where the sperm matures, where they are stored. And then, of course, during ejaculation, the sperm are pushed out of the epididymis through the vas deferens, the spermatic cord or duct or tube. Vas deferens is what I use. And then it works its way through the vas deferens up into the pelvic cavity. It does not go into the bladder though, right? Okay, it goes around the bladder, and then it goes through a little area called the prostate gland, and then into the urethra. So here in the prostate gland, you actually have the vas deferens communicating with the urethra. You guys see that okay there? You have communicating. And then of course, we know the prostate gland secretes lubricating, protective substances, mainly for the sperm as they travel through. It provides materials that they need to survive long enough to do what they need to do when they get out. You guys okay with that? Okay, so that's the basic anatomy and physiology. The epididymis is divided into three sections. You have the tail, which kind of wraps around the posterior, the inferior part of the testis, and then you have the body, which is a major part, and then you have the head, which is the most superior part. And the interesting thing about this whole unit here is that its blood supply is very localized. Okay? And that is to say that you have one specific area where you get blood into and out of this, and that is vessels that kind of surround the spermatic cord as it goes into the scrotum is another name for it, the testicular sac, the scrotum. And so we know that it is potentially fairly easy to compromise that vascular supply. We don't have really any collateral circulation if this supply becomes compromised. So if it does become compromised, then that is actually a medical emergency, okay, because this can become necrotic. And then, of course, that can lead to very, very bad things. So you guys okay with that? That make sense? Okay, now if you look at the penis actually has some specialized structures as well. It has the urethra that goes through the middle of it, of course. Okay, and the penis is attached to the pelvic wall through what's known as a suspensory ligament. And it basically attaches the base of the penis to the pubic bone, or the pubis symphysis. And we know occasionally there are surgeries that are done involving the suspensory ligament, penis enlargement surgery, where that ligament can actually be cut and more of the penis will kind of hang outside of the body there, and so it can have some potential cosmetic advantages. But as you might imagine, if that ligament gets cut, then is that going to cause some problems with control of the penis? Yeah, it's going to come down. It's not going to have the same kind of anatomical features that you would expect if that ligament was intact. But what's particularly important for us is there are two types of with the exception of the urethra, there are basically two areas. You have what's known as the corpus cavernosum and the corpus spongiosum, and the spongiosum is kind of the soft, spongy tissue. And what is relevant when talking about the corpus cavernosum? What goes on there? Guys?
Sensory?
No, not so much sensory. Guys? Kind of important thing, right? There you go. It fills up with what? Yeah. So the cavernosum is it's like a cavern, right? It's like caverns, and basically this becomes engorged with blood, and you actually have little valves that close off the venous drainage of the penis. So you have arterial vascular supply coming in, and then you don't have a venous outlet. And so what happens is the cavernosum becomes engorged with blood. It fills up, and that's what causes an erection. And we know in people that have erectile dysfunction due to like coronary artery disease, peripheral vascular disease, diabetes, right? Anything that can cause damage to your vessels and your nerves over the long period of time can cause erectile dysfunction, right? Because how does this work? Well, generally you have sensory input, right, that comes into the body, and the brain interprets that sensory input in an erotic manner, and it could be tactile input from here, or it can be visual or auditory input, whatever the case may be, and then the brain sends efferent information down, right, causes those valves to close and an erection to ensue. And anything that can damage the vascular supply or the nervous supply chronically can result in dysfunction. And are there medications that potentially may help? Yeah, specifically the phosphodiesterase inhibitors, right? The phosphodiesterase inhibitors, and they alter nitric oxide pathways, right? Just like nitrates, right? Like nitroglycerin interacts with nitric oxide, inhibiting nitric oxide pathways, causes vasodilation. Well, guess what? Erectile dysfunction drugs can do much the same thing. They can cause diabetes. They can cause things to open up and close, and that's what helps here. And interestingly enough, does anyone know, did the first drugs that came onto the market for erectile dysfunction, were they developed specifically for?
No, they were harming it, not the side effects.
Not a heart med, but you're close. Huh? No. They were actually developed they were trying to treat pulmonary hypertension. Yeah, they were trying to treat pulmonary hypertension. We know increasing levels of nitric oxide in the pulmonary vasculature can cause smooth muscle relaxation. Yeah, so they were actually developed to treat pulmonary hypertension. And they noticed when they started doing testing, they noticed side effects, including erection and things like that. And that's where the more common application of some of these agents have come from. Viagra, Cialis.
Did it work for the pulmonary hypertension?
Yes and no. There are actually drugs that are very specific to the pulmonary vasculature that kind of piggyback on that. And we talked about this in respiratory. Remember, some people carry pumps on them. You guys remember talking about the little Flolan, where they have a continuous infusion. So basically like an insulin pump, and they have to have a continuous infusion of these medications. And remember, if anything interrupts those infusions, they can abruptly decompensate. Yeah, so Viagra itself, not so much, but certainly we piggyback on research onto that, and there are other therapies that have been developed for pulmonary hypertension. Flolan is one. There's a newer agent, a couple of newer agents on the market. I disremember their names. Flolan has actually kind of fallen out of favor because its half-life is so short that if it gets disrupted, your patients can just die right on you. And so there's some newer agents that if they get disrupted, it's you have like up to a few hours, I think, to get the infusion going again. And so I think that's where most people with these devices are going toward these newer agents. Okay, you guys good with that? Okay, so that's just kind of the basic anatomy and physiology. Let's talk about some of these male-specific problems. Let's go ahead and talk about paraphimosis and phimosis first. And what do these generally mean? What area of the male genital urinary tract are we focusing on here?
The forcing?
Yeah, we're talking about the forcing. So this is specific to uncircumcised male patients. And what does it mean if somebody has phimosis? We're unable to do something.
They can't retract the foreskin.
Cannot retract the foreskin. And paraphimosis is difficulty retracting the foreskin. And a common cause of that is something called ballantitis. And what is ballantitis? Well, trauma may cause it. It's often like the irritation or infection that causes ballantitis. But what is ballantitis? Never heard of it? The book didn't talk about it at all?
Not that
It is.
Not cleaning? Yeah, it's right there.
It's right there. It's an inflammation or infection of the glands of the penis. Yeah. The glands. So the glands gets inflamed, infected, it swells up a little bit, and it makes it difficult to retract that foreskin. So that's where the complaint's going to be, right? What can we do about this as paramedics?
Amen.
Yeah, diddly squat. We can't do a whole lot, right? Other than get a good assessment, right? Get a good assessment, get a good history, have an idea of this is what we're dealing with, right? And then manage the patient appropriately, right? Possibly pay med if they need it. Okay.
Yeah, I did right there, I see that, okay. I missed it.
It's all right. Okay, let's move on to another problem called priapism. What's priapism?
Persistent erection.
A persistent erection, right? Why is this problematic, having a persistent erection?
Damage.
Blood pressure issues.
Right, because you don't have good blood flow, right? This is kind of a no flow state, and you can potentially develop ischemia and possibly even infarction of the penile tissues, right? So they say an erection that lasts more than about 3 or 4 hours is considered very problematic, right? Again, is there much we can do to treat this? Not really, other than can we identify certain causes?
Yes.
For example, what are some potential causes of priapism?
Lower spine injury.
What's that?
Lower spine injury.
Okay, some sort of neurological insult, absolutely, right? We need neural insults. And then we want to be thinking
ED drugs,
drugs,
cocaine.
after that, right? Yeah, cocaine, might be involved in that, right? Erectile dysfunction drugs, right? I went to Vegas and took a bunch of Cialis and, or whatever, right? And this may be in younger people, right? These drugs are very common actually in younger people for their supposed performance enhancing effects or what have you. But again, the risk of priapism is going to be there. What can we do? Not much, right? Other than assess, identify, try to find certain causes. Okay, being good historians, supporting the patient, getting them to where they need to go, and then what's going to happen? What's the initial treatment for this? What I know in area. Yeah. Okay. Okay. Let's talk about now. So we kind of started at the periphery, right? And we're working our way more centrally, if you will. So let's now talk about testicular torsion. And this is a true medical emergency. This is a true medical emergency. This is kind of like that AAA patient. And that these patients need to be rapidly evacuated. Okay. And what is testicular torsion?
Twisting of the.
Yeah, so if the testis gets twisted around and the vascular supply gets compromised, that's going to cause immediate ischemia to this area. And tends to present with sudden onset excruciating pain. May or may not be associated with trauma. Oftentimes, testicular torsion occurs spontaneously. And what patients are more prone to developing testicular torsion? Younger patients, kids actually, yeah, younger patients. Yeah. And when you do your exam of the testicle, it may not be particularly remarkable. Oftentimes, you're not going to see a whole lot of swelling, right? It's just going to be incredibly excruciatingly painful. And guess what? That makes sense, right? Because remember when we talked about mesenteric ischemia, right? Where they have this excruciating pain because their guts are dying, but the rest of their exam is kind of like, right? So again, you kind of have that pattern repeated here where you have an interruption of blood supply and what does that leads to ischemia, severe pain. You guys okay with that? So what do? Right? Investigate, support, rapid transport, pain management. Right? There's not much else we can do other than suspect what's going on and get them where they need to go. Oh, going back to priapism, there is a disease process that may make some people more prone to priapism, and you guys guess what it is. It's a disease we really haven't talked about yet. Sickle cell anemia. Yes. Never mind, you guys are all over it. Yeah. As remember, as particularly with the sickle cell crisis, right, you get micro clots occurring.
So it's just a clot.
Yeah, including venous outflow in there. You guys are all over it. Wow. Big deal. Okay, so let's now move on to epididymitis. And what is epididymitis? Inflammation of the epididymis. Cool. What commonly causes epididymitis?
Sexual transmission.
Okay, so in your adult patients, okay, you should suspect STD. Okay, chlamydia, gonorrhea. Okay, really top of the list, right? And what has reached the United States now? Speaking of STDs, it's finally reached our shores. Drug resistant.
Oh, gonorrhea. You're just talking about the drug-resistant one.
Yeah, we've never seen it here. It's been a problem in Europe, and now some cases have been seen in Hawaii, so it's coming. Which means it's gonna be really hard to, really hard to treat, right? Like,
Nah.
imagine,
Just stay away.
yeah, just imagine somebody dying from gonorrhea, or if you get gonorrhea, it's not well. Hopefully your immune system can take care of it. Hopefully it doesn't make you sterile or kill you. So kind of a terrifying thought. So all the more reason to educate people about safer sexual practices, right? It's not as easy as just giving antibiotics. You don't have effective antibiotics for some of this stuff. Okay. The other really common cause is actually viral. Epididymitis is often more commonly caused by a virus, particularly in our younger kids that develop this. Like mumps, for example. It's commonly seen after following a mumps infection, which isn't particularly common in the United States because of MMR vaccine. But as we know, there are growing communities of people that do not vaccinate their children themselves, and so we may run into these problems. How does this present? Or does it even present differently than, say, testicular torsion?
Sometimes they have burning when they urinate.
They may have burning when they urinate.
Discharge.
They may have discharge. Okay, good. But those are real non-specific, right? Like dysuria, which is painful, or difficulty urinating.
Low abdomen pain, flank pain.
Yeah, so they may develop some pain. It may radiate into the abdomen. And the pain may be very positional as well, right? And so when you look at the testicle, if you move the testicle in a way that puts pressure on the epididymis, it's going to increase the pain. And if you decrease that pressure on the epididymis, the pain will decrease, right? And the testes tend not to be tender, right? So have you guys all done testicular exams? Is that something that you've ever done? Huh? Yeah. Well, you got guys, right? You should be doing it like every month, right? What do? Well, you pull the scrotum down a little bit, and then you identify kind of the harder part, right? It's a firm area in there, and that firm area that shouldn't squish and should feel very firm and smooth is the testis, right? And then you kind of have a little baggy area on the posterior aspect of it, right? And that little baggy area is the epididymis, right? Right. And that's one of the things you do, right? Is you feel around. Do I feel any lumps, right? You should feel a little baggy, you should feel firm, but you shouldn't have any lumps or bumps, because that may indicate a problem, right? Well, if you palpate the testes, they may not be very painful. So those findings are going to point you more toward the diagnosis of epididymitis. Again, how do we deal with this as paramedics? Get a good history, get pain control, pain management if they need it, and then take them to where they need to go. All right, cool. So moving on to some other testicular issues, varicoceles. What is a varicocele? Yeah, it's a varicocele, right? It's, you can have esophageal varices, you can have hemorrhoids, right? They're all pretty much the same pathophysiology. Yeah, you have a dilated area of veins. Varicoceles tend to present like kind of the dilated lumpy area, and it tends to be along the spermatic cord where you feel that. And oftentimes people make a mistake that for cancer. They'll feel this lump and go, oh God, and then they'll go, oh, it's a varicocele. Varicoceles can occasionally become painful. If they become a little dilated and inflamed, they can become painful. And they can present similar to like an epididymitis, they can cause lower abdominal pain, so on and so forth. I will also say that people that have epididymitis tend not to have significant nausea and vomiting. It tends not to be a feature of epididymitis, but if they have testicular torsion, they will almost immediately start having nausea and vomiting, in addition to this excruciating pain. Okay, you guys okay with that? Again, what can we do about varicoceles? Not a thing procedurally. So again, it's going to be coming down to history, getting where we need to go. Orchitis. What is orchitis?
Inflammation, testing.
Of the testes, right? And you can also have something called epididymal orchitis, which is both of them, right? Yeah. And orchitis may be very difficult to differentiate from epididymitis, or it could be a combination. And it's not as important for us to nail the diagnosis as it is to recognize the causes of epididymitis, the causes of orchitis, and then investigate those, right? You know, how old is my patient? What things are more likely in that age group, right? And then try to get some good focused history. Get a good sexual history as well, if you can. And then I also want to talk about testicular cancer real quickly. Testicular cancer almost always tends to be painless. Painless lumps, that tends to be how it's initially identified. Or that's what causes somebody to activate the healthcare system if they have a painless lump. And then testicular cancer is one of the most treatable types of cancer, though, believe it or not. It's actually reasonably well treated in a lot of cases. And again, if somebody's been treated for cancer, general cancer considerations, right? Reverse isolation, assessing for infections and things like that, right? Because you know that they have immunosuppression. Okay, you guys okay? Yeah.
I don't know if you've heard, or because this is just like talking with other healthcare providers, or nursing homes and stuff, but they said don't rule out the old STDs with the older people because apparently they don't use protection.
Never. Yeah.
And so
That's like one of the biggest populations of especially HIV
yeah.
is in elderly patients. Yeah.
Yeah,
There's kind of this illusion, all right, I'm past menopause, woo, don't have to worry. Okay, you know. Yeah, no, you're absolutely right. You cannot rule out an STD in somebody who's older, right? Because guess what? We're all going to be older, right? And we're probably all going to think about sex when we're older, right? That hasn't changed as I've gotten older. I doubt it'll change. Who knows, you know, maybe if I have a bad stroke or something like that, but yeah, you know, I know it's kind of a weird thing to think about, but older people are active as well, and they may not be as proactive about their health, like you said. Yeah, that's a really good point. Yeah. So, like, basically, any adult male that has a urogenital complaint, you need to be thinking about the possibility of an STD or STI, sexually transmitted infection. Yeah, for sure. Okay, let's move on to the prostate then, because this is a very common problem in people. So we know where the prostate is, we know that it's a gland, and we know that it can be problematic, and we know that after about the age of 35, that darn thing starts enlarging. Right? And that's a condition known as benign prostatic hyperplasia. What is hyperplasia?
Cells get bigger.
Is that the cells getting bigger?
Sorry, cells are dividing.
It's cell division, right? Hyperplasia is cell division. Hypertrophy is an increase in cell size. Going back to the cell response lectures we had in pathophysiology. Cool. So this just kind of happens, right? About 35, it just kind of happens. And that can cause problems, right? That can cause difficulty urinating, right? Because remember, your urethra goes through the prostate, right? So if that gets enlarged, that can make it more difficult to get urine through that enlarged prostate, right? Occasionally, it can be so bad that we have to actually place a urinary catheter into our patient to facilitate good voiding, get them to be able to urinate normally. Okay, it's very common. Every guy is pretty much going to have to deal physically in order to some extent. And then we have something called prostatitis. What is that?
There's 4 types.
That's an inflammation of the prostate.
There's 4 types.
What's that?
It said there was 4 types.
Yeah, there are several types of it. It can be even idiopathic. We don't know. It can be infectious. It can be traumatic. It can be related to a whole bunch of issues. How does prostatitis tend to present?
Difficulty urinating, incomplete voiding.
Yeah, so difficulty peeing, right? You like, wow, I can't get out, or when I go pee, just a little bit kind of comes out. What's going on here? And then they often will have fever, chills, or they'll look like they have an infection as well. Right? And so if somebody has difficulty urinating and they look like they can have an infection, may not be the urethra or the bladder that's involved. It very well may be the prostate. And then another prostate problem that's relatively common is prostate cancer. And again, this is not something we'll find for the most part. This tends to be something that's found during medical exams. Once you get to be about that age, what happens? The finger goes in, right? And what are we looking at when we don't, but when a healthcare provider inserts a finger into the rectum, they're actually feeling, right? They're feeling the posterior aspect of the prostate. And they're feeling really for 2 things. They're feeling for bumps. The prostate should not have any bumps on it. If it does, then that warrants further investigation. And if you guys all kind of take your hand and go like that, kind of flex your hand with your palm, and you feel that there, that's what a prostate should feel like. Put your finger on it. That's what it should feel like. It should kind of have a firm feeling to it. And then if you relax your palm and you push in, see how it's kind of soft. If you feel, well, not you, but if a prostate feels soft like that, that's what we call a boggy prostate. It's boggy, and that is often an indication of a prostate problem, prostatitis, for example. How do I know that? How would I know something like that?
Because you question the doctor as he was asking, or as he was doing it. Oh.
No.
Because you've done this to
Yeah,
somebody.
because I had a urologist telling me what was going on while she was doing the exam on me.
Yeah. She was just telling you, she was just giving you the information.
Yeah, a couple of years ago, I ended up in the emergency room, was having bladder spasms, and I couldn't pee. It was really bad. It was actually awful. And they couldn't figure out what was wrong with me because my urine was clean. I didn't have it. They did a UA, and I was like, what's going on? They did a CT scan, and I was like, hey, here, why do you have so much pain? So they sent me over to the urologist, and she went in and did her exam, and then she pulled her finger out. She's like, and this is, whenever somebody says this, something's up. So she's like, okay, I need to go and check with some resources. I'll be right back. When anyone says that they need to check on with resources, that means, oh, something's wrong and I need to do some research.
What is
yeah.
it? What is it called?
Called a boggy prostate. Yeah. And again, this is not something you guys will be doing, but it is helpful to at least understand the language of what's going on, because if you can communicate with particularly physicians, if you can communicate with them better, they have more trust in you, they allow you to do more things, they take your word for it. When you say something to them, they take it more seriously. So it helps just linguistically and just from a continuity of care standpoint. But yeah, so I ended up having prostatitis, and I had to go on antibiotics for a month, even though there was no indication of bacteria. So they thought it was due to biking. I just started biking. That is actually one potential cause. It's a fairly rare cause. And I bike so much now that I'm not sure that that's really what causes it. I bike incredible amounts now. But they also found my prostate was enlarged. She's like, but, you know, hey, you're over 35, and that just happens. Great. Great. There you go. Okay, you guys okay with that? Alright, cool. And then finally, we'll talk about Fournier's, or Fournier's. I think it's Fournier's gangrene. It's a French word, so Fournier, I believe, would be the better pronunciation. This is nothing more than a form of necrotizing fasciitis that involves the perineal area. And does everyone know what I mean when I say perineum, the peri area, the scrotum? Yeah. This is life-threatening though, right? This is a necrotic, rapidly evolving disease. One of the things that you can do is if you suspect this, and it's, you know, it can look pretty bad, pretty noticeable. If you see lines of discoloration or demarcation on your patient, you know, if it's like purple or black, if you have like a Sharpie, draw a line there and then chart the time. Okay, because that allows us to see how quickly this is evolving or spreading. This is a true medical emergency here. Okay, the only way that we can potentially save somebody with any kind of necrotizing fasciitis is to get them into the operating room and to radically debride that tissue, cut all that stuff away, radically debride it. That really is the only way. So if you suspect this, you don't really have a whole lot of time to dork around on the scene doing this and that and the other thing, right? This should be okay, rapid transport. Like this is a type of necrotizing fasciitis. If you have the ability to place a Foley catheter, that may be helpful. Okay? In all of these cases, a Foley catheter may be helpful in facilitating urination, because it is possible, right? It is possible to have bladder damage due to inability to void, rupture. Who was oh my goodness, I just forgot his name. Yeah, he was not ancient. It was an early Renaissance. He was kind of an astronomer, philosopher. I'm so embarrassed I forgot his name. But he ended up getting his nose cut off in a duel, and so he wore a gold nose around. But anyway, he was at a dinner party and had to pee, and it was considered rude to leave, and so he stayed for hours and hours until his bladder ruptured, and then he ended up dying. Yeah, this is like the 14 or 1500s. Oh my goodness. You know, I should be able to remember this guy's name, but I don't. But I remember this. I just remember he had a gold nose that got the tip of his nose cut off in a sword duel. That was pretty common, you know, people duel. Even here in the U.S., people, you know, in the early 1700s, dueling was a fairly common thing. Presidents, right? Jackson.
Oh, is it
Tycho Brahe. Tycho Brahe. Yeah, there you go. Yeah. So there you go. Yeah. Look at that. My Google scholars. You guys are on it. All right, you guys good with that? Any questions? Does that kind of make sense? Excellent. So let's move on to, and I've even color coded these for you guys. So the green stuff's all guy stuff, and then the blue stuff, that's kind of stuff that can affect anybody. So there we go, color coded just for you guys. All right, let's talk about probably one of the most common urinary complaints, and that is UTI or urinary tract infection. Okay. And so that is just a broad term that means an infection or inflammation somewhere along the urinary tract. So that could potentially be basically from the kidneys all the way down to the distal urethra. Right? Could be all or part of it. And so there are different terms for a UTI in different areas of the body. There is something called urethritis, which is going to be involving the urethra. Cystitis is going to involve the bladder, right? Bladder. And then pyelonephritis is going to involve the kidneys. And you could also have ureteritis, I suppose, which would involve ureters. Okay. How does your run-of-the-mill UTI present? Okay, so dysuria, right? pain, difficulty urinating. Good. Huh?
Fever.
Fever, chills, discolored urine, right? Urine should kind of have an amber-like color to it. If it has a more cloudy color to it, that may be pus, white blood cells, bacteria in the urine. If it has a T, what if it looks like T, dark T?
Blood.
Yeah, blood, specifically if you have like a T or kind of a cola colored urine, you want to be worried about rhabdo in that case. Okay, good, good, all right. What is a typical cause of UTI? Bacteria. Yeah, bacteria. Say it again. E. coli is a more common cause. And why? Where does that come from? Yeah. No rectum. Typically gut bacteria. So you're talking gram-negative organisms for the most part. E. coli is a really common one. Okay. Who does this tend to be more common? When? Why? Well, we mentioned this earlier. Shorter urethra, yeah. Shorter urethra is much easier for bacteria to get into the bladder, colonize the bladder, and cause lots of problems. If you have a male patient with signs and symptoms of UTI, you must always assume STI. Yeah, you must always put that in your differential. UTIs tend to be fairly rare in men. Okay, tends to be fairly rare. And if a man does get UTI, there's a much higher probability that that is an STI versus a woman where it could be an STI, but it very well could be simply enteric bacterial colonization. The exception may be elderly or disabled patients, right, where they may not be able to care for themselves or urinate normally, and there may be situations there.
Isn't that also with Foley catheters?
Yes. Anybody, like we talked about yesterday, anybody who has anything implanted is going to be at a significantly higher risk for UTI. So they have a Foley catheter, and that sometimes is why we go from a Foley catheter to the suprapubic, right? Is because in some cases the suprapubic may have a lower complication rate, lower risk of infection, because you don't have that tube rubbing against the membranes of the urethra for the rest of that patient's life. So the suprapubic may have less risks of infection, assuming that it's well taken care of. Yeah, absolutely. You guys okay with that? So yeah, these patients present pretty similar to some of these other disorders, right? So if you have a male, your workup may be a little more complicated than the female. In some sense, there are actually lots of specialized female anatomical structures as well that are complicated. So in general, complaints that are below the diaphragm are really tough to work out. In a lot of cases, we'll need to do ultrasounds, right? We'll need to do ultrasound of the scrotum, the bladder. We'll need to do specialized testing to figure out what's going on. Clearly, what is one test that most people with any kind of urinary complaint is going to need? A urinalysis, right? And we talked about how we can interpret the UA in a little more detail yesterday. Okay, good. Pyelonephritis, however, may present very differently than somebody who has a lower urinary tract infection, right? How might pyelonephritis present? Flank or the costovertebral pain and tenderness, good. In addition to, the chills and that. Yeah. So where their pain is, where their complaint is, may help you zero in on where the problem might be. Okay? Because again, how are we going to treat somebody with a suspected urinary tract infection?
Fluids.
Okay, might need to give them fluids, right? If they're tachycardic, they have a fever, okay, their lungs are clear, you should probably give them some fluids, for sure. All these